In this video, we're going to look at some of the basics about erythrocyte homeostasis. As you can imagine, it's very important not to have too many and not to have too little of red blood cells, that you just need to stay within that homeostatic norms or limits. And not surprisingly, that what we're looking at is really a negative feedback control. And it's a very simple one in many ways, is that you have a drop in red blood cell count that causes kidney hypoxemia. And just break that word down, of course, low oxygen in the blood. And the kidneys in response will release erythropoietin, also known as, often called EPO. So they release erythropoietin, which is a stimulant for the bone marrow to start to increase the number of red blood cells. And after a few days, we start to have that increase occurring in terms of the path of development of the red blood cells. Now, what can stimulate this? There's a number of things. It could be hypoxemia. A patient who is having issues with maintaining their blood oxygen levels. A number of conditions can do that, emphysema, etc. Also high altitude. If you go from low to high altitude, that could also stimulate it. Increase in exercise. We see this in certainly in athletes as they increase their training, or the normal person. And also, as I said, emphysema, loss of lung tissue and emphysema. So there's a number of causes that lead to this. And the basic pathway is that we have hypoxemia, which is sensed by the liver and the kidneys, and they are sources for the hormone EPO, erythropoietin, stimulates bone marrow production, which accelerates the rate of red blood cell development, and I end up with an increased red blood cell count, and therefore I'm carrying more oxygen, and hopefully you've corrected the hypoxemia. Now, how about red blood cells, getting rid of them and recycling? Because, of course, we talked about this in a previous video, that they do not have a nucleus. They don't have most of the organelles in it, so they cannot repair themselves. So they have a very limited lifespan. So when they start to get old and worn out, is that red blood cells will lyse in channels of the spleen. And when that occurs, the macrophages in the spleen will help to basically digest the membrane bits. And then we get a bit of recycling happening. We can separate the heme from the globulin. And then the globulins are broken down into their component amino acids, so they can be reused. The iron is removed from the heme, and then the heme pigment is converted into biliveridin, for green. Biliveridin gets converted into bilirubin, yellow, and released into the blood plasma. And of course, this is one of the things that adds to the coloration of urine, the yellow in the urine. The liver removes the bilirubin and secretes it into the bile. And often it really is concentrated in the gallbladder and to be released in the small intestines. And there it becomes urobilinogen. And that is one of the colorants for feces. Now, this diagram just sort of summarizes that we have in the small intestine, we have nutrient absorption, things like amino acids, iron, folic acid, vitamin B12. We get erythropoiesis in bone marrow. They circulate for, on average, about 120 days, and then they enter special channels in the spleen, liver, where they are broken down. The cell fragments are phagocytized, and the hemoglobin is broken down. The globin is basically hydrolyzed into free amino acids. The heme, as I said, the iron ends up part of storage, getting reused or lost in things like injury or menstruation. And then for the heme, biliveridin, bilirubin, bile, feces is the pathway of that. Now, of course, there are a number of disorders that are related to either having too many red blood cells or not enough. And we call an excess polycythemia, so an excess. And we can divide that into two groups. We can divide it into primary and secondary. Now, primary, typically we tend to think that as a cancer of the erythropoietic cell line. And in some cases, you can actually see that the hematocrit, remember that's the packed volume of red blood cells, can be up to 80%. Secondary polycythemia is from other causes. This could simply be dehydration, that I've lost some of the water component of the blood, and then functionally it looks like I have more red blood cells. Emphysema, because of the hypoxemia, it could result in basically overproduction of EPO, erythropoietin, and would increase the red blood cell count. High altitude can do it, or as I said, physical conditioning. And you can get a significant increase through those too. Now, are there dangers? Why don't we just go for having a lot of red blood cells? But there's some dangers to it. Is that one of the side effects could be an increase in blood volume, blood pressure, and of course viscosity. And if you remember, viscosity was one of those resistance factors that we talked about when we first started the cardiovascular system. And that helps to basically, or would oppose things like cardiac output. And of course, all of this can lead to embolism, stroke, or heart failure. Of course, none of those are terribly desirable. Anemia is a lower than level of either cells, or the cells don't have enough hemoglobin within them. And what are the causes? Well, maybe I'm not making enough red blood cells, or maybe I'm not making enough hemoglobin. What could lead to this? Well, certainly if you had kidney disease, maybe you're not able to produce the erythropoietin. Remember, that's a hormone that stimulates this. Maybe I'm iron deficient. And being iron deficient, I may not be able to make the adequate hemoglobin. Also, inadequate levels of vitamin B12, poor nutrition, or the lack of something called intrinsic factor. And we're not going to go into great detail of its role right here. We could also have categories which were hypoplastic anemia, which is a slowing of red blood cell production, or aplastic. See the word aplastic. A often represents, designates no or highly reduced. So aplastic anemia. In this case, I could have a complete stop of erythropoiesis. You could also have hemorrhagic anemias from the result of bleeding, or hemolytic anemias in which the red blood cells are being destroyed. Now, what are the consequences? Because certainly there are consequences. One would be tissue hypoxia and necrosis. And not surprising with this, a patient would tend to be lethargic, shortness of breath, and of course, if it becomes extensive, then we're looking at potential multi-organ failure, especially those organs that are really oxygen dependent, brain, heart, kidneys, etc. Blood osmolarity is reduced. And of course, when we had our discussion about capillary exchange, as soon as you play around with osmolarity, you're affecting the colloid osmotic pressure, which is the force that will draw some of the fluid back into a capillary that's being put out into the tissue, and the result would be edema. Also, when blood viscosity is low, the heart races, pressure drops, and it may actually result in cardiac failure. Now, I just want to, as an add-on, just mention sickle cell disease. It's a hereditary disease, happens within certain populations, often associated with a more direct African descent. And what are we really looking at? We're looking at a recessive allele that changes the structure of the hemoglobin molecule, and often what we actually do refer to it as HbS in terms of that allele and the resulting phenotype. It's a very small difference that we're looking at, differs only on the 6th amino acid of the beta chain. I'm not going to hold you responsible for that, but I want to at least give you some idea. Now, what's the problem here is that the sickling version of the hemoglobin does not bind oxygen as well. The other thing is that the red blood cells often lose their characteristic shape. They become rigid, sticky. Often they become pointed at the ends. And if we look here, you can see sort of a more normal looking red blood cell, but we can see a red blood cell that's undergone sickling. Now think about this shape as it's trying to pass through blood vessels, especially small blood vessels. That is not an ideal shape. And you can see how this could lead to clumping, etc. And not surprising, if it's getting stuck in blood vessels, you can have a lot of fallout from that. Such as it can lead to kidney or heart failure, stroke, rheumatism, or paralysis. So there's a lot of issues around the sickle cell condition. And of course, if you look at your textbook, it has a greater discussion about sickle cell, and many intro to biology books will talk about sort of the potential evolutionary history of the sickle cell condition. Well, we're going to end this video here, and the next video we're going to look at blood groups.